my presentation. A 50-year-old female with painful enlargement of right breast. A 50-year-old Bangladeshi housewife presented with painful enlargement of right breast for 2 months with redness of the whole right breast. There is no significant past medical or surgical history. She is non-smoker, non-alcoholic. Her family member is suffering from such type of diseases or other malignancies. Locally diagnosed as breast abscess and suggested for antibiotics, she took homeopathic medications for this reason also, but the pain didn't subside and worsened even more. There is no history of fever, cough, hemoptysis, jaundice, bone pain, or headache at the time of admission. Her menarche started at the age of 13 years. Menstrual cycle is irregular, polymenorrhea. Her age at first childbirth was 15 years. Age of last child is 14 years. She took oral contraceptive pill for 4 years irregularly. On general examination, no abnormality detected. On local examination, breasts are asymmetrical. Right breast is situated upwards, slight comparison to the left one. Overlying skin is erythematous. Purity orange changes and nuchal retraction are present. Part of areola is ulcerated. Right breast, local temperature raised and tenderness present. Left breast is normal. Both axilla couldn't be evaluated due to event. Investigation findings: ultrasonogram of both breasts and axillae. Left breast, focal fibrocystic change at 2 o'clock position, subareolar region of left breast. Right breast, multifocal, highly suspicious for malignant lesion at 10 and 11 o'clock position in right breast. Axilla, bilateral axillary metastatic lymphadenopathy, diffuse subcutaneous edema in both breasts. Core biopsy from right breast mass, invasive ductal cell carcinoma, grade 2, lymphobascular space invasion not seen. Fine needle aspiration cytology from left axillary lymph node, positive for malignant cell, suggestive of metastatic adenocarcinoma. Immunohistochemistry report reveals ER/PR negative and HER2 positive. This is the chest X-ray while he was admitted in our ward after 15 days of admission. Her chest X-ray posterior anterior view shows homogeneous opacity on right side with blunting of costophenic and cardiophrenic angles on the same side. The patient underwent thoracentesis of right side on 26th September 2020 and 1000 ml of serous fluid came out. After that, a chest drain tube was inserted 3 days later in right-sided pleural cavity and 1200 ml of serosanguinous pleural fluid came out and the tube kept in situ on emergency basis. The patient underwent fluorosis with bleomycin following chest drain tube removal on 17th October 2020, about 1 month later. Meanwhile, a consultation with Oncology department was done and they advised capecitabine oral chemotherapy. Patient could not afford trastuzumab therapy. This is my presentation, and my question is, and the questions needed to be discussed is, what will be the further evaluation options? What will be the best treatment option in case of low effort trastuzumab? What is the prognosis of her with this type of disease presentation?
Thank you, Dr. Sadia, for presenting a very advanced case, I would say. I want to go to Ben Park, sir. What is your comments? Or if you have any question regarding this case, you can ask them, you can go to discussion.
Clinically, this looks to me like she's presenting as an inflammatory breast carcinoma. And it's something that we usually would give systemic therapy up front. For someone who's HER2 positive, as I was already mentioned, we would use obviously trastuzumab with chemotherapy and maybe even add Perjeta to that, which is another HER2 antibody therapy. If that's not available, I think having a triplet drug regimen of AC and T, and probably dose-dense AC followed by either weekly Taxol, or some people also still prefer to use dose-dense Taxol, would be our upfront choice. We might want to stage her because this is inflammatory breast cancer, and if she has other symptoms, some people may advocate for that. And then my, thought process on this is we'd hope for some sort of clinical response to this. That's probably the only advantage of inflammatory breast cancer, is that you can follow it clinically as well, and then take her to surgery, assuming that she does not have overt metastatic disease. I think the hard part about this is, before the advent of HER2-directed therapies, HER2-positive breast cancer was probably the worst prognostic breast cancer to have. And getting to your question 3, I don't think that this outcome will be much different unless she has the ability to get some sort of HER2-directed therapy. And so if that's at all available to her, that would probably be most of our recommendations. I think the other question would be, as I mentioned earlier, is genetic testing available for BRCA1 or 2? And if she cannot get a PARP inhibitor, a platinum chemotherapy regimen may afford benefit as well. So that's also something that potentially could affect her management. But it's unfortunate if she can't obtain trastuzumab. That really is the best option for curative intent. And even patients with really advanced disease, we're talking stage 3B, and I'm convinced even some patients with true overt metastatic disease, if they can get HER2-directed therapies, we have cured some of those patients, which goes against conventional thinking. But at least in this country, if breast oncologists have seen enough metastatic HER2-positive disease, we all have had a handful of patients that are without evidence of disease, and I even have one that has stopped her maintenance Herceptin for now almost a decade and is still without evidence of recurrence. So there are real success stories and miraculous ones out there. And again, I think that that's indicative of the fact that she really does need some HER2-directed therapies.
Thank you, sir. Thank you, sir. Now, Rajesh, sir, what is your opinion regarding such cases? You have seen such advanced cases both in Bangladesh when you're here, and also you're seeing a lot of such advanced cases with resource-setting situation as well as poor patient. So please, your opinion.
Yeah, as Dr. Ben has said, my thought would be like to start with chemo. Basically, either doxorubicin, cyclophosphamide regimen. If she's not able to afford the trastuzumab, pertuzumab combination with the taxane, then other option would be to try at least an AC chemotherapy, anthracycline, cyclophosphamide, or you could go for the much cheaper regimen, CMF regimen, which might still be having effectiveness when compared to the other one than the capecitabine. So that would be my option. Maybe whenever if you want to add capecitabine, maybe you can try adding along with lapatinib, which is another dual HER2 blocker. So that drug is also a bit cheap in both India and Bangladesh when compared to trastuzumab. But overall, her prognosis is going to be poor because it's a metastatic HER2 positive tumor, but she's not going to afford for Herceptin based regimen.
Thank you, Rajesh, sir. Comments from Salim Reza, sir?
Thanks, Dr. Arunangshu. Definitely, this is an advanced case. I am in favor of mainly the just what Dr. Rajesh mentioned here, that is the chemotherapy first with adriamycin, that is doxorubicin, and cyclophosphamide. It may be dose dense or it may be 3 weekly. Then, if possible, then after 4 cycles, we'll go for the taxane, that is platelets regimens. As the patient is not affordable for the trastuzumab or the pertuzumab, if possible, as the drug of our lapatinib and capecitabine is available in Bangladesh and also comparatively cheaper than the originator products, so we may also use these drugs, capecitabine plus lapatinib. But I am not favor in only using the capecitabine in these stages.
Actually, many a times we surgeons face very difficulty in managing such type of cases. Coming in such an advanced case with the opposite axilla positive with the pleural effusion, malignant pleural effusion, and we surgeons don't have any option or anything to do or give comfort to the patient. That's why the discussion is, I think, is very crucial, how we can give a little bit comfort to this type of patients in our context. And we actually faced problem with this patient managing because the financial capacity was so poor that without except the capecitabine, the patient couldn't afford anything. And I think it was not a good option. But the recommendations that you have made, that is not possible for many of our patients to afford. And that's why the case discussion is there. What else can be done for this patient?
Any other panel member or anyone want to comment on this case?
I think this is actually we are facing more problem because of financial matters comes up first in our, especially in treating the patient in our country. And this is a very advanced case from Dhaka because they have shown actually I think the financial is a handicap. That's why the department has prescribed the only capecitabine in that cases. But this patient should have a chemotherapy because this is a inflammatory breast cancer with a pleural effusions. Patient needs a chemotherapy. Chemotherapy is cheaper that can be afforded by our patients in our country because chemotherapy is supplied by also the government hospital and the cancer institute. But to block the HER2s, I think what Rajesh has told, we can add lapatinib because this is also produced in our countries, and that is also affordable, and sometimes it is given by the hospitals like National Cancer Institute. I think we should think we should have some local experience with our local managements like local transport. I think that should be some centers, especially with the low resource people in our countries, and we should try some protocols by our own, because all the patients cannot afford that trial what has been done with the European American studies, especially. That's all.
There is a comment regarding metronomic therapy. What's your opinion?
In our view, metronomic therapy has not really been tested enough to be clinically proven as an alternative. And so, there are some anecdotes, there are some phase trials, none of which have really made an impact for breast cancer, at least on changing our guidelines and thinking. I think in this case, though, because Herceptin is not available, I would probably, again, try to get something else. And I think the lapatinib idea is a great one if it's affordable. It is not, upfront therapy in this country and has fallen out of favor due to the development of other tyrosine kinase inhibitors, including neratinib and tucatinib recently. But I think in this particular instance, because there's no good outcome other than the standard chemotherapies, whatever happens after that or beyond that, I think would be worth a try. In my view right now, I would still probably use a standard approach of dose. If chemotherapy is available, I'd probably first use dose-dense ACNT and then see how she responds, maybe take her to surgery if we're sure that she doesn't have evidence of metastasis. And you might consider doing something like a lapatinib capecitabine in the future, because if that's available.